Welcome everyone to our session on protecting the vulnerable during the flu season with great tips on how to stay healthy for this flu season. My name is Laura Tamblyn-Watts and I am delighted to welcome you to this presentation by the Canadian Frailty Network and CanAge, supported in part by grant of Sanofi Pasteur. At this point, I'm going to turn the session over to Dr. John Muscedere to open our session. John, over to you.
Hello, and thank you, Laura. And I'm John Muscedere. I'm the scientific director of the Canadian Frailty Network, and I'd like to thank all of you for taking time out of your busy day to attend our webinar. And I would also like to especially thank our panelists on today's session for agreeing to provide this very valuable information. The Canadian Frailty Network's mission is to improve the care of Canadians living with frailty and to support their caregivers. And influenza vaccination and vaccination in whole is an important key of how we can key aspect of how we can improve care for people living with frailty. It's part of our avoid strategy, which includes promotion of activity. V is for vaccination, and the rest are optimization of medication, reduction of social isolation, and promotion of diet and nutrition. So we're going to proceed shortly to the webinar, and I'm going to turn it over to Laura Tamblyn-Watts, who I'm delighted to have as moderating this session. Laura is the president and CEO of CanAge, Canada's National Seniors Advocacy Organization and Voice of Seniors in Canada. She's a lawyer, an advocate, researcher, and media commentator. Her work focuses on law, aging, abuse, accessibility, law reform, governance, and knowledge mobilization. Laura serves on a number of boards across Canada and currently teaches at the University of Toronto, where she is a fellow of the Institute of Life Course and Aging. With all those responsibilities and duties, we are very fortunate to have Laura as a moderator on our session today, and it's my pleasure to welcome her to this afternoon's webinar, and please take it over, Laura.
Thanks very much, and thank you to all. I also want to particularly acknowledge that I am coming to you from Nova Scotia, where I am on traditional McMaster territory. And for those of you who are following the news, St. Mary's Bay is just across from where I am right now. So the Indigenous piece is very important, and I just wanted to make sure that we started that. I also wanted to acknowledge the traditional territories of the Anishinaabe, where the Canadian Frailty Network has their main location. Just as introduction, I want to thank our sponsors, Sanofi Pasteur. This session is partly sponsored by them, and we're so pleased from an arm's length educational grant that we are able to bring you this important information today. A quick overview very quickly about who the Canadian Frailty Network is. You've heard that from John, a little bit companion for who is it from CanAge. So our organization seeks to advance the rights and well-beings of Canadians as we age. We are a neutral, nonpartisan advocacy and policy organization that works, as I say, across this country to improve the lives of older people. I want to just take a few minutes to talk about why are we talking about the flu and vaccinations from that perspective. We have just released, and we invite you to have a look at our Voices of Canada's Seniors, a roadmap to an age-inclusive Canada. And we have 6 major themes that we've identified in this plan of action for aging for all Canadians. The I in this is infection prevention and disaster response. And I would offer that never before has that conversation been so vital to Canadians. I also want to share that not only are we thinking about, our COVID lives and what we need to do in order to better support information uptake about a possible future COVID vaccine, but the most important thing that you can do right now in terms of vaccines and awareness is to go get your flu shot. So this session is about understanding the different kinds of flu shots, what is the appropriate flu shot for you or people that you are caring for, and to be able to answer questions that you may have. So before we kick into the main session, I just want to take a few seconds to engage in a couple of details. For those of you who are old hands at Zoom, you will know that on your bar for your tools on screen, you may see 3 dots and says more, or you may already see a little bubble that says chat. We invite you to click on that and to participate with us through the session. So we will be in our chat engaging and answering your questions. So hi, everyone, you'll see that there. So do tell us who you are. Thank you so much. We've got some person already who have joined in here, and I'm very pleased to hear both who you are, what you do, what organization you're with, and where you're calling in from. So do feel free to use the chat as an engaged function. Part of what we're doing today is teasing the best out of our expert panelists. So we have the Q&A, which you will see 2 little bubbles, and it says Q&A beside it. Feel free to drop your questions in there. I have some questions that were previously submitted. We'll be blending those with the questions that you submit as well. We'll be monitoring the chat in case issues arise in there as well. Thanks, Shannon. We're glad that you've joined, and I invite others to join into our chat as well. So we will be using our chat and our Q&A very dynamically, but you will stay muted. So it's good for you to know that in case you're worried about any type of background noise. In the framework of our conversations today, we will really delve into some important issues. And I'm going to take just this moment to introduce all 3 of our panelists at the same time, and then I will invite each of them to take the proverbial stage in turn. So our first expert panelist is Dr. Mark Loeb, and Mark is a professor of pathology and molecular medicine and a clinical epidemiologist and biostatisticians at McMaster University. So in case you are trying to figure out who actually, is the epidemiologist as opposed to, in this case, family members or friends who are amateur armchair epidemiologist, Mark is actually the real thing. And his focus is really on infections in the elderly. He does a lot of work in randomized trials for influenza vaccine, and he's been also engaged in cohort studies with regards to COVID-19. Again, one of our fabulous experts is Dr. Melissa Andrews, and she's an associate professor of medicine at Dalhousie University, not too far away from where I am right now. As part of the Canadian Immunization Research Network, she's a co-principal investigator of the Serious Outcomes Surveillance, or what we call the SOS network. And she's looking at how frailty impacts both the vaccine effectiveness and the clinical outcomes of influenza and pneumococcal infections in older people. Great to have you with us, Dr. Andrew. And our last of our expert panelists, Dr. Kumanan Wilson. He's a specialist in internal medicine and scientist at the Ottawa Hospital, professor of medicine at the University of Ottawa, and an innovation advisor at the Briere Institute. But he also holds a Faculty of Medicine clinical research chair in digital health innovation. And really interestingly, he's also the CEO and founder of a wonderful digital immunization platform that we love here at CanAge called Can Immunize. And we're going to help to tease out a little bit more about that digital platform during his discussion as well, and how you can benefit from using it. And Dr. Wilson's research is very focused on public health security and immunization. So with no further ado, at this point, I'm going to invite our first panelist, Dr. Loeb, to turn on his camera and also load his slides. He can share his screen. I'm so grateful that Dr. Loeb has taken the time to do it. I know that when you're out there trying to focus on key questions that are driving the hearts and minds of people right now, that epidemiology and questions of vaccinations are at the forefront. So thank you very much, Dr. Loeb. With that invitation, I'll invite you to unmute your video and take over the slides.
Okay, thank you very much, Laura. Thank you for the kind introduction. So I'll be speaking about vaccination. So The objectives for my talk will be to review how vaccines work and specifically go over the types of vaccines that exist. And I'll discuss a little bit about the challenge of successful immunization in older adults. Also go over the importance of influenza vaccination and give you a brief update on COVID-19 vaccines. So this is just a synopsis of how vaccine works. So basically, vaccines introduce either a whole virus that's been inactivated or pieces of the virus. And what happens is that the immune system's antigen-presenting cells will take parts of that virus, so either the whole part of it or bits or pieces of it, and they will present them to cells called T cells. So these T cells, and they're cells called B cells, they recognize the virus and they rapidly expand in number. Some of the T cells will directly infect your own cells that have been sort of infected with the part of the vaccine, which is part of the virus. And other cells will secrete signals to direct the immune reaction. So it's almost a sort of really orchestrated type of response. So we have T cells that will prompt the B cells to produce antibodies. These are sort of Y-shaped molecules that help block viruses from infecting cells or mark the pathogens for destruction. So this is a vaccine is almost like a simulated infection. And a small part of the T cells and the B cells go into become memory cells, and they basically spring back into action when your body sees the real virus. So there are a number of types of vaccines, and I thought I'd just briefly go over them. First, there's inactivated vaccines. These could be viruses that are chemically treated and they're not live. Then there are live vaccines. They are generally attenuated viruses, so they don't make you really ill. They create just a very mild infection, creates a natural type infection. Then there's subunit vaccines that are just those bits and components of the virus that prompt your immune system to produce a response. Then there's recombinant vectors, and this is a little fancier. These are sort of designer vaccines that really insert part of the DNA or RNA of the vaccine into a virus that goes and infects your cells and creates an immune response. And then there are nucleic acid vaccines that are just bits of the blueprint, RNA or DNA, that are just directly taken up into cells and then manufacture a response, lead to a response. This is a slide just showing the many sort of immune deficits that occur in older adults, whether it's problems with the innate immune system, cells phagocytosing, problems with natural killer cells, antibody production, those sort of Y-shaped components that we talked about, cytokines, which are signaling molecules. All of these are deficits in seniors. So I'd just like to move on now to influenza, and this is a slide of the influenza virus. And the important thing to see here is the hemagglutinin, and this is the sort of protein that really binds to your cells and it starts the infection. And the vaccines are directed against the hemagglutinin. And this slide really summarizes what happens in terms of an entire community that is in the midst of a influenza epidemic. So children are that sector of the population that often gets infected first and has the highest infection rates, as you see over here. They get infected predominantly at younger ages, younger children, and can spread the flu to seniors and other adults. It's important to note that the hospitalizations occur at the extremes of ages. So the very young and the very old tend to get hospitalized, but unfortunately it's the very old who again don't have those host defenses who will succumb to the illness. In terms of the types of specifically influenza vaccine, one can think of them as being divided into trivalent or quadrivalent vaccines. So the trivalent vaccines include two types of influenza A, an H3N2 and H1N1 antigen, and one type of B. So these trivalent vaccines are gradually being phased out because it's always been a guessing game as to which type of influenza B would circulate. So the vaccines, more modern vaccines or updated vaccines are quadrivalent that include the H3N2, the H1N1A, and 2 types of B. So everything is all covered, all the Bs are covered. And there are, even within that, you could break it down further, that the trivalent and the quadrivalent vaccines are indicated for all ages. The live attenuated virus vaccine, rather, is targeted towards children. The adjuvanted trivalent influenza vaccine works both for children and in the elderly. An adjuvant is just a molecule that sort of revs up or stimulates the immune system. And then the high-dose influenza vaccine is a vaccine that has about 5 times the amount of hemagglutinin, and that produces a rigorous or robust immune response in older adults. This slide is just to show you the effectiveness of the vaccine based on those subtypes, the types of influenza that we've been talking about. And I just want to direct your attention to the lower part here. You see that the effectiveness in most studies of the vaccine against H1N1 is pretty good at about 60%, and type B is 63%. But for H3N2, and that's one of the viruses that tends to cause a more severe infection, standard vaccines have a lower effectiveness of only 24% or so. So in order to get a better response, I mentioned that there are high-dose influenza vaccines, and this is just a table just showing the sort of response. So basically shows that when we compare a high-dose vaccine in a randomized controlled trial to a standard dose, there's about a 30% benefit with the high-dose vaccine. So that's good. The other type of vaccine is an adjuvanted vaccine. This isn't a randomized controlled trial, but again, it shows a benefit of the adjuvanted vaccine to help protect older adults. In terms of safety, influenza vaccine is a safe vaccine. Serious adverse events are rare. Usually the side effects are local adverse events like pain in the arm or redness or swelling there. Anaphylaxis, which is a severe allergic reaction, is the most serious adverse event, but it's very rare. Egg allergy is no longer a contraindication. Really, the only contraindication is a previous anaphylactic reaction. And there are many common myths about the flu vaccine. People will say, oh, I got the flu shot last year and I got the worst flu of my life afterwards. Well, that doesn't really make sense because it's not a live vaccine, so it's not giving people the flu. The fact is that there are other viruses that circulate at the same type of year, and you get your flu shot and people put the wrong bits of information together. Another one, isn't it better to not get the vaccine and get natural protection? Well, you certainly could get natural infection, but you could die as a consequence. So that doesn't make sense as well. So the other is chemicals in the vaccine are toxic, and that has been purely debunked. So there's nothing in the vaccine that's toxic in any way. I thought I'd just end this by just saying a little bit about COVID-19. This is the SARS CoV-2, and really what's important to see here is the spike glycoprotein. So the vaccines are targeted against that component of the virus, and the types of vaccines. Well, there are different types of vaccines that are being tested right now in phase 3 large randomized clinical trials, but some of them have been. They don't have the same track record as inactivated vaccines, but we're hopeful that they'll show an effect. One of them is a recombinant vector vaccine, where you take that spike, you take the nucleic acid from the SARS-CoV-2 and you insert it in an adenovirus, and that goes on. It's injected into people, and then that adenovirus infects their cells and produces an antibody response. Or another one is a subunit vaccine that I mentioned a few minutes ago, that it's really free-floating protein, or nucleic acid vaccines, which there's a whole bunch of these they're just taken up directly into the cell and produce an immune response. And the key thing, of course, about the COVID vaccine is that, generally speaking, it takes 10 years to go through the process of academic research to preclinical trials to phase 1, phase 2, phase 3 clinical trials. All of that has been really condensed, where phases are combined, and where the manufacturing process has to begin before you even know whether the vaccine will be effective. So we're hopeful that either at the end of this calendar year or sometime in the new year, there will be effective vaccines that'll protect people against COVID-19. So my last slide is that seniors are at high risk for infection and related complications, that their response to vaccines can be challenging because of immune waiting. It's very important to get a high uptake of influenza vaccine in older adults. And we eagerly await the results of the early phase 3 COVID vaccine randomized controlled trials. Thank you very much.
Thanks very much, Dr. Loeb. It was wonderful. And it's so helpful to actually get the science behind it and to understand. There's some questions in the chat about who gets covered for what, and we'll come back to that in a minute. I'm going to invite our next panelist to the front, but also just really wanted to make sure that we'll get to questions at the end of the 3 presentations, but don't hold back. If you are interested, make sure you put your questions in the Q&A, and we're having some good coverage chats right now as well. Feel free to join in this chat. So at this point, I will turn it over and ask Dr. Andrews to unmute her video as well and join us and take us through her presentation.
Great. Thank you, Laura. I appreciate the opportunity to be here. Also joining from Mi'kma'ki, the traditional unceded territory of the Mi'kmaq people. And I'll be talking today about why this is really so relevant for older adults in terms of this frailty piece that features in the name of the Canadian Frailty Network, for example. So just for disclosure, some of my research is funded by collaborations with industry, which is listed here. So the key points that I wanted to cover today are really these 3. So one is that the burden of influenza is often thought of as a short-term illness. So we think, oh, we get sick and we get better after a week or 2. But we really, especially for older adults, need to consider longer timelines and the impact on function and independence and ability to live in one's own house. The second point is that the symptoms that older adults may present with could be different from what we might be expecting. And that has implications when we identify and diagnose the flu. And the third thing is that influenza can really contribute to worsening frailty and function. And it's so important to do what we can do, whatever we can to avoid frailty. So just in terms of what frailty has to do with influenza, just a bit of a definition for frailty for those who might be unfamiliar. So the idea of frailty is that it's somebody being in a state of being vulnerable to bad things happening or getting worse in terms of their health. And somebody who's robust and not frail can take a hit such as a minor illness, an infection, or a more significant illness like influenza. They would feel unwell at the time, their function would go down. I think you'll see it here, but then they may bounce back relatively easily. But somebody who's more frail, so just hovering above this dotted line that shows where you'd start to need help in your daily activities, someone who's managing at home but just sort of barely gets an illness like influenza, tips down much farther in terms of their daily functions, so they need help, they can't manage at home, and they may or may not recover all the way back to the point that they were before. And so that frailty really captures that idea about being vulnerable to these sorts of health events. So I'll be presenting some results of research that we've done in our Serious Outcomes Surveillance Network, which is a national network of hospitals across Canada where we've gone looking for cases of people being admitted to hospital with influenza over many years. This is the 10th year that we've been running it. And we're quite unique in our network in similar networks around the world, in that we focus on older adults and we measure frailty. So I'm actually a geriatrician, and that's my role within this network. So we have a couple of different measures of frailty. One is a frailty index, where we do sort of a comprehensive evaluation of the older person's health and wellness, and then add up the problems that they have, and that gives an indication of their frailty. The other measure of frailty that we use, that some people might be familiar with, is the clinical frailty scale, which again assigns categories. Everybody would fit in this, not just, it's not an age specific thing, but of where we are in terms of our function and our overall health. So essentially in both of these, the higher the score, the worse off somebody is in terms of frailty. So just a couple of points, and this builds on what Dr. Loeb was talking about earlier. So one is that we notice that as people get older, there's better uptake of vaccination. So that's the pie charts in the top. So these are our hospitalized adults. The younger ones, unfortunately, only 20% of them or so have had the flu vaccine. This does increase with age. But importantly, we also see that the really bad outcomes, the death and being admitted to the ICU, intensive care units, also definitely are affected by age. So we find that the mortality or the death rate in the younger adults is 4 or 5%, which is still significant, but much lower than what we see in the oldest age groups of about 14 or 15%. Intensive care admissions, usually it's about 20% of our people, or 1 in 5 people getting admitted to hospitals may end up in the intensive care unit. That does go up with older age, but what we'll see in the next slide is a bit more of the story when we think about frailty. So when we divide up the patients, these are the people admitted to hospitals by frailty, what we see is that also the vaccination rate tends to go up. So in our most frail older adults, 62% of them or so, or almost 2 in 3 have had the flu shot, but that really means we've missed the opportunity with the other 1 in 3. And these are people with flu and not with flu. And in comparing the likelihood or the chances of people ending up in hospital who have or have not had the flu shot, we can calculate the effectiveness of the vaccine. And as Dr. Loeb showed, our effectiveness estimates tend to be in the 40 or 50% range every year, which means that the risk of getting hospitalized with a serious enough case of the flu to land you in hospital goes down by 50% if you get the flu shot. Now, we know also that we need to consider frailty in these calculations. And we've found that when we adjust for frailty, people who are older adults or who are on the less frail ends of the spectrum have very good responses to the flu vaccine, perhaps as good as younger adults too. So frailty is a really important piece of how older people respond to the vaccine. Death, of course, increases a lot with frailty. And so it's a really vulnerable population that we need to be protecting and developing even better flu vaccines and choosing the best ones among those we have. Putting together our results from a number of different seasons, here's an example of what would happen to 100 older adults who live in the community. They would live in their own homes. Some of them might live in nursing homes already, but most of them live in their own homes, say 9 out of 10 or 95% even. They get admitted to hospital with influenza. What happens to them? Well, 12 of them would unfortunately die during that admission. We have 68 of them who walk out the door with reasonably preserved function, so similar to what their baseline level of function was. But unfortunately, what we see is that 20 out of the 100, or 20% of them, have a decline in their function that lasts much beyond when they've left the hospital. So in the case of these 9 people here, the yellow ones, their decline in function is moderate. So they need a bit of extra help compared to what they did before, but they're still probably able to return home. Unfortunately, what we see with these 11 people who I've shown in red is that their function has declined in a catastrophic way. So they are now dependent in 2 or 3 or more basic activities of daily living. So this is things like getting dressed, going to the toilet, feeding yourself. It's not like doing your taxes and making Thanksgiving dinner. Like this is very basic things. So if you lose, if these 11 people have lost 3 of those daily activities, it means that they need a lot more help from friends and family. Their quality of life is dramatically affected. And in fact, what we see is that about 3 out of the 100 people have a new need to go to a nursing home. So it has a really dramatic effect when we break it down in these terms. What we want to do is prevent the people from getting into the hospital in the first place. With regard to that point about diagnosing influenza in older people, really the main point is that if you wait for fever and cough, like the traditional symptoms that we think of with influenza, we'll miss more than half of the older people who are sick enough with influenza to need hospital stays. If we put that another way, 55% of older people who are admitted in a hospital don't have fever and cough. So we need to be a little more creative when we think about what symptoms somebody has and realizing that they need a test and proper treatment for the flu. So hopefully this short talk has helped to contextualize things a bit with regard to frailty, and that it's important to understand frailty in identifying influenza illness and also when we consider the outcomes. And in particular, when we think of how effective influenza vaccination is and who really needs good coverage with influenza vaccines and better vaccines. So here's our stages of frailty. This is the frailty scale, as I told you, the 1 through 9. So what would potentially happen as people get older is that they might decline in their frailty, but that doesn't have to happen. What we would like to see, in fact, is that people stay at a good level of frailty or even improve. And that's one of the important initiatives from the Canadian Frailty Network with what's called Avoid Frailty. And these are 5 simple things or relatively simple ideas in any event that can help prevent frailty. And the V there stands for vaccinate. And there's further information on this website, avoidfrailty.ca. So that's the end of what I was hoping to say. I'll be happy to participate in the Q&A afterwards.
Thanks so much, Dr. Andrews. Really helpful and so clear to understand. I've captured a few of the high-level points in the chat box. We'll let you get off the stage right now. We'll invite our next speaker, Dr. Wilson, to take our stage. You know, it's so helpful while Dr. Wilson is getting himself sorted out that we understand not just how important it is, but also kind of how to track it, and that we can better understand where it may be that, say, 2/3 of the population we're talking about are getting the vaccine, 1/3 aren't, and how important it is to get the vaccine. Quick reminder as well, please feel free to participate in the chat. Tell us what you're thinking about, what your concerns are. If you've got a question, do drop it into our Q&A. That's being monitored constantly. And we're excited to welcome our next speaker and invite Dr. Wilson to turn on his camera and take the stage.
Thanks. Laura, can you see the presentation?
We can, we're perfect, thank you.
Great, thanks. Thanks for inviting me, and thanks to the Canadian Frailty Network for putting this on. So I'm going to speak briefly about how to reduce the spread of influenza and COVID, although I'm sure by now you've all heard a lot about the latter. So I will review this, even though we are hearing great advice from our public health officials regularly about the importance of this, because it really is at the heart of how we control the spread of these infectious diseases. So the safest thing you can do is obviously be home alone, and we would do that in situations where virus is spreading in the community from person to person and is out of control. But the lower level risk activities are to be outdoors within social bubbles or outdoors with physical distancing. Obviously, risk starts to increase when you're either outdoors or indoors and in close proximity with each other. And the Canadian Digital Services contact tracing app is based on identifying within 15 minutes of proximity of an individual who may have subsequently developed COVID. You will receive a notification. The highest risk activities are indoors in large groups for long times, or outdoors and indoors in very large groups. And that's what we start to hear with these public health measures which restrict these types of activities. Fortunately, with the flu, we have another measure available, and we've been hearing, and that's the flu vaccine. And this is our best way to prevent the flu. And this is in particular important for those with high risk of influenza complications, which include pregnant women, people above 65 years of age, children between 6 months and 5 years of age, and people with chronic medical conditions. And also importantly, people who live with or care for those at high risk of having these complications. There was a famous study in Japan conducted which showed that vaccinating children with the flu vaccine had a significant impact on mortality and pneumococcal infections, pneumonia amongst the elderly, showing the surrogate benefit of vaccinating one population to benefit another. And along with this vaccination, all of the measures we're now taking for COVID can also help reduce the spread of influenza. And we're starting to see this in the Southern Hemisphere where influenza spread has been markedly reduced presumably because of all of the COVID measures. And as the others have mentioned, one of the keys to reducing influenza morbidity and mortality is to focus on the high-risk groups. And the over 65 is one of those high-risk groups. So we need to ensure that they are protected, that they receive the flu shot, but we also, those of us who are around them and in close proximity, need to make sure we're taking the right public health measures and protecting ourselves so that we don't develop the influenza and spread it to them. So these are the recommendations for the National Advisory Committee on Immunization for the flu vaccine. So this is they're recommending it for people at high risk of influenza complications or hospitalizations, which again are adults over 65, people with chronic health conditions, and people of any age who are residents of nursing homes and other chronic care facilities. And there are 4 vaccines that are authorized for use, and Dr. Loeb did a great job of explaining the differences between these. But they recommend the high-dose vaccine which has good evidence of better protection compared to the standard dose vaccine in adults over 65. And as Dr. Loeb mentioned, this is because as you get older, your immune system starts to wane, it starts to forget, it doesn't have quite as strong a response, and it needs to really be reminded, and to be triggered to develop that immune response that's going to be needed when influenza virus is presented to it. And we have a really good evidence for the benefit of this high dose vaccine. So this is a meta-analysis of 7 studies. This is a combination of 7 randomized controlled trials. And it found that the high dose vaccine demonstrated better protection against influenza-like illness compared to the standard dose vaccine. And the relative effectiveness was about 20%. And when you look at the relative effectiveness for hospital admission, it was around 9%. For influenza, around 18%, pneumonia was 25%, and cardiorespiratory events, it was about 18%. And importantly, against post-influenza mortality, it was 22%. So this phenomenon of the immune system waning in older adults and the inability of a standard dose vaccine to perhaps be as effective as it needs to be can partially be addressed by using these high dose vaccines. And you've probably seen this in the news now. It's particularly important to get the flu vaccine this year because of what people are referring to as a twindemic, the circulation of 2 respiratory viruses simultaneously. And here's the problem. It's very hard to distinguish COVID and the flu. And as everybody is being asked to take measures as soon as they have COVID-like symptoms, if we add in a large percent of the population that start to develop flu-like symptoms, you can understand the implications of this on individuals personally and on the system as a whole. So here are the risks we're confronting, the 2 circulating respiratory viruses, the difficulty to distinguish, and the immediate implications of this could overburden our testing system. So you develop symptoms that you can't tell the difference between flu and COVID, and you will have to go get tested to ensure that you don't have COVID. And importantly, our systems are already at the brink with COVID, and adding the burden of an influenza season on top of that could push them over the edge. But there is some good news. One is that social distancing, the measures we're taking to prevent the spread of COVID, have had an effect in reducing the spread of influenza in the Southern Hemisphere. So if we just keep up with those good public health measures, that will be an important step in reducing the spread of influenza. And unlike COVID, we do have an actual intervention that can help, the influenza vaccine. And so this is the year to get your influenza vaccine, even if you've been ambivalent in the past. It's something active you can do that can help with this pandemic. If you can reduce your risk of getting symptoms that are going to place you in a long lineup that for testing, this would be the measure that could do it. Of course, there are a lot of other good reasons to get the flu vaccine, protecting your health and protecting the health of those around you. I'm just going to close with some comments about how technology can help. So this is the Pan-Canadian digital immunization platform we developed called CanImmunize. It's freely available on both Android and iOS, and on web-based platforms, and it allows you to track your vaccine. It's for the whole life cycle, so it's not just for children, and you can track your entire family's vaccines on it. And it provides you with accurate information on vaccines. And it allows you to record your vaccine and have a personal record for yourself. But importantly, while we like to talk a lot about the anti-vaccine movement for why people don't vaccinate, the most common reason people don't vaccinate is logistics. And people just simply forget. And digital prompts, digital reminders, which we built into CanImmunize, have been shown to be very effective in improving vaccination rates. So, another meta-analysis showed that these prompts can improve vaccination rates by 20%. So this is a very simple thing we can do to improve immunization. And we're now developing this platform to help older Canadians. So we're going to be launching this in Briere probably next week, where we're enabling healthcare providers to track vaccinations using this platform and then share records of that with the individuals who've been vaccinated. And we built in the ability to distinguish the different types of flu vaccine, which is important. And this will be particularly important with a COVID vaccine, where there could be up to 6 in circulation at the same time. And importantly, the system will provide a record back to the individual. So the institution will have a record of the vaccine, and they'll be able to create their aggregate statistics and have their dashboards, but an individual will know they received the vaccine, they'll receive a digital badge, and then they'll be reminded next year it's time to get another vaccine. And we've also been working with the Canadian Immunization Research Network to help with adverse event surveillance for the flu vaccine. So every year, a system called Canvas recruits healthcare providers throughout the country. And after the vaccine, they receive surveys periodically to see if they developed any serious adverse events. We've now built that into CanImmunize, and we're actually implementing a randomized trial now to see if mobile reporting of adverse events is just as good as the current system. And the idea here is, if it is, it's that way we can broaden our adverse event surveillance beyond these healthcare providers to potentially all users of CanImmunize. And again, we think this could be really helpful when a COVID vaccine is released. I'm just last words are some hope. This just came out yesterday. A COVID-19 vaccine being developed by the University of Oxford and AstraZeneca showed a promising immune response and low levels of adverse reaction in the elderly and older adults, according to an interim analysis. So this is great news. A vaccine may be available soon, and it might work in older adults. And I thank you for your time.
Thanks very much. And we really appreciate that. End with a little bit of hope. At this point, I'll invite you to stop sharing your screens, and I'll invite each of our panel to come to the fore so you can unmute your videos, and we've got a bunch of time for Q&A. Lots of great questions that have been submitted. We're also working on Facebook Live, so if you're joining us from Facebook or YouTube Live, feel free to pop your questions into the comment section. We've got eyes on those as well. Look, I'm going to start off with a question that Jennifer had, and Jennifer Pond asks, is there a shortage of flu vaccine this year? And I know that many of us will have seen some news reports of long lineups and so on. Are these long lineups or this sort of lack of coordination from some community clinics indicative of a shortage of vaccine? Who would like to take that one? If not,
I can take a quick stab.
The answer is no. Go ahead.
Yeah, so I mean, there appears to be more demand for a flu vaccine this year than usual, which is great news. And the initial estimates of how much vaccine a province gets is I think in Ontario was at 40%, and the usage of the flu vaccine will likely exceed that, but it shouldn't be a problem. They should be able to get that provided over the course of the flu season.
I've got one that was submitted from before, and it's a fairly quick and easy one. So I think we should dispel a key myth. I've got a question for all of you. Some people have concerns about the safety of the flu shot. Is it possible to get the flu from the flu shot?
Well, I guess I can take that because I spoke a little bit about that. If you're particularly if we're talking about seniors, it's not it's not a live vaccine, so it is not possible to get the flu from the flu shot. In fact, as I mentioned, often there's other reasons. Sometimes there's other circulating viruses, non-flu viruses that happen at the same time. So there's almost a confounding between someone who might develop any respiratory symptoms of respiratory infection and got their flu shot, and they put it together, but it's really a false association.
That's perfect. I'm going to follow on a couple more questions that were submitted as well. Well, we have one question that says, well, can seniors get multiple regular flu shots in replace of one high dose flu shot? So we're talking about prompting the immune system. Who would like to take that one?
Well, I think I can speak to that. That's not recommended. So the idea behind a high dose is really to create such a boost at one time in the immune system. So I would stick to recommended vaccines and not to try a do-it-yourself type of approach like that.
Thank you. One of the questions that we also got, I think I'm going to just answer because Dr. Wilson really did it. One of the questions was, if you're taking the precautions like wearing masks, social distancing, and hand washing to prevent COVID-19, shouldn't that help to prevent the flu too? And Dr. Wilson, you said address that very specifically. We're seeing in the Southern Hemisphere that there have been reduced influenza incidences because, the same good protocols are being used. So I can only hope that that's the case this year. I'm going to head back over to our Q&A chat.
I'll add just something, a little point about that. Our Canadian network is part of a global influenza surveillance network. And we just recently had our meeting with all the different sites, some of which are in the Southern Hemisphere. And what we heard from them is that while they did have a reduction in the number of people with the flu, they were in severe lockdown, as in they couldn't, like some of these countries like South Africa, for example, they couldn't leave the house at all. After a certain hour, they would have had curfews. There was no liquor stores open. The bars were all closed, even more than here. So if we want to count on that type of thing protecting us from the flu, we would be under much more strict regulations than we even are with COVID. So again, it's just the point that we should do everything that we possibly can. In the case of flu, we do have vaccines. We should be getting those.
Yeah, and I was just speaking to a colleague yesterday from Melbourne, Australia, the first time where they had no cases, but they've been under lockdown now for about 7 months. So it is important to know we're not just talking about apples and oranges. We have an interesting question here, and I'm going to blend two questions together. One question was from Janet, and I'll just read this out with Jennifer's as well. Why would anyone build anything but a high dose vaccine? Is it cost? Is it production? And then the corollary to that was, one of the people that Jennifer knew said she became very unwell after receiving the high dose flu. So I guess that question is, can you choose whether to get it? So two-part question. Why would you have a flu vaccine that's not high dose? Step one. And then number two, if you're an individual and you fall under a category to get the high dose, can you say no to that? Who'd like to jump in on those two questions?
Well, I can just speak to the first one at least. They're different. High dose is one strategy and adjuvant is another. So, they're different types of approaches. And those are the two main approaches that exist. Why would you not, why would you do anything other than the high dose? Well, it's something that's evolved, right? Science evolves, people realize that there's still a problem with standard dose, and then these new formulations, these new ways of mounting a better immune response occur, basically.
Yeah. So not a one size fit all, different approaches for it. That same piece I just wanted to build on. So we have a question of patient choice, and actually I'm the lawyer on this one. I'm going to give you it's actually a legal answer that you're not looking for, not a medical answer. Do you have the right to say, no, I don't want this type of flu vaccine, not the other? The answer legally is yes, of course. If you're entitled to qualify for the high dose flu, but you don't want to, you can choose to have a different type of flu vaccine. The corollary problem is the harder one because of coverage, and that is at its end kind of one of those health inequities that you may run into. So if you want to get the high dose flu vaccine, but it's not covered in your jurisdiction, it can be much more difficult. In fact, it can be very difficult to get a hold of it. John, I want to turn to you for a second, if I may. You're working in ICU on a regular basis. You are working with an older adult population, and you're looking at questions of frailty. Are there any insights that you can give to us about, what's happening in ICU, and what do you want to have not happen in ICU this year?
So thank you for the question. So in my clinical work, I see the results of people not getting vaccinated with influenza. And outside of the COVID years, we always see an uptick in admissions to ICU directly related to respiratory tract infections, and a lot of them are influenza related, or the consequence of not getting influenza and then getting another infection, such as a bacterial infection that causes pneumonia after getting influenza. So we're always relatively full in ICUs in the winter months because of respiratory tract infections. And the most important thing to realize is that it's not a short-lived problem if you're admitted to ICU with a respiratory tract infection. People have long-term consequences of those things that may never recover. And it gets down to the same as Melissa's slides, where people never recover to their baseline form. Even if they're younger, they may have persistent problems with their memory, with their ability to think. They may never get back to being to their normal selves. So it's not just that you get unwell, you get ICU, and then you get better. It's that people have prolonged effects from those admissions, and certainly influenza is one of those things that are preventable to stop you from winding up there.
Thanks very much. Yeah, we certainly don't want to see you into the in ICU. We have an interesting question from Susan. Susan says, my sister got a flu shot from her doctor this September, so September 2020, and then she realized it was last year's flu shot. Is it okay for her to get another flu shot now? That's one I haven't heard before. Perhaps Dr. Loeb, you might want to jump in on this one.
Yeah, it wouldn't be a problem. It's important to be updated. So the antigens have been substantially updated in the flu vaccine, so it's important to have a current vaccine. And if she got one at the end of last season or whatever, getting one this flu season is not a problem.
That's helpful. I want to dovetail a little bit into that intersection question of sort of frailty and concerns about COVID and influenza together, which is a really important context for us. We've got a few questions that work in this area. Christine Carlson asked the question, when testing for the flu or COVID-19, is there a difference in accuracy of testing via the throat or nasopharyngeal swab, which I've had? What a joy that is. I've heard that some places are testing using both methods, while some just use one of those testing methods. So she's wondering about the pros and cons about testing via a throat swab or a nasopharyngeal swab. But perhaps maybe John, who you're in the healthcare system right now, or you're interested in testing, is that something that speaks to you?
Sure. So for influenza, we use a nasopharyngeal swab, although we can also take other samples from the lungs and send those off to to be tested. What we currently are using, at least in our hospital, is a nasopharyngeal swab for COVID, and they're set for very different type of tests because they're very specific for either one.
Yeah, thank you. And I'm going to ask a question. We have Gul joining us from the UK. Welcome. I'm so glad you came here. He's got a couple questions. I think, Dr. Andrews, this is for you, probably, talking about who is immunocompromised, who is frail, and so on. And his question fits around the question of where do diabetics fall in this category? Diabetes, the great underpinning, the great comorbidity that we're always looking for. Can you speak to the intersection of frailty, flu, and diabetes?
Yeah, great question. So one thing that we sometimes have this misperception about is that frailty only starts when people are over 65. But certainly people who are younger than 65, if they have multiple medical comorbidities and health and functional challenges, could be frail as well and vulnerable. There are conditions like diabetes, obesity is another one, and some cardiovascular problems, lung difficulties that would all affect our immune responses to a respiratory virus in different ways. And there may be some inflammation, for example, that also affects our ability to respond to vaccines. So it's a good question. We tend to think about them as separate issues, but there probably are quite a lot of similarities. Yeah.
Yeah, I'm going to follow up on that one. And this is one that I'm sure you've all answered many, many times, but it is one of those sort of pervasive questions. I just put it in the chat. I'll read it out, though, is there are stories of people who get the flu shot, but still get the flu. Okay, well, we know about that, but I'll get someone to speak to it. Does this mean that the flu shot isn't effective? Why do some people get sick after getting the flu shot? And that is a really common one. Perhaps Dr. Loeb, I might come to you about that. So the question is, again, you might get the flu shot, still get the flu. Does that mean it's not effective? And why do some people get sick after getting a flu shot?
So there are sometimes vaccine failures. I mean, the flu shot is not 100% like any vaccine. So you can have if the estimates are generally speaking, and I'm speaking about the broader population now, about 60%. So there will be individuals who might fail. Then the evidence, I'd say, is mixed about whether having a flu vaccine, getting the flu, whether the severity will actually be reduced. There's mixed evidence in the literature. It's certainly suggestive with the live attenuated vaccine that'll reduce the severity. I would say that there are some studies that have suggested that the severity might be reduced, but there are other studies that suggest, at least in moderate illness, severity might not be reduced. So I would say it's sort of a mixed bag. So that's when someone gets the flu after having been vaccinated. Your other question was more about someone getting sick after getting the flu shot that we talked a little bit about. They're getting, they think they got the flu. That's often confounded by other respiratory viruses. Of course, there's there are some adverse reactions that tend to be very mild after the flu shot. Some people can have a low-grade fever. Some people can have some redness on their arm, etc. That's really the immune system that's reacting to the introduction of an antigen, and it's your immune system, how your immune system gets trained to protect you from a real virus.
I'm going to, thanks very much. I'm going to finish with one last question, and it really is an important one. This is a question from Heather, and Heather Burke from BC says, how can my mother, who's 84, and myself, who's 59, immune compromised, get the high dose vaccine? Only in her jurisdiction in British Columbia, people in long-term care facilities can get it. This is a question of health equity, and one that we are all wrestling with. Does someone feel like they would like to speak a little bit to the process for who gets covered interprovincially? If not, I'll do it.
I can take the first stab. So NACI would make the recommendations on who should receive the vaccine, but just because NACI makes a recommendation doesn't mean it gets funded at the provincial level, and though the decisions made by the provinces independently. So would depend on advocating in your province if a vaccine is recommended by NACI that it should be funded at the provincial level.
Yeah, and I'll just perhaps build on that in our last minute and welcome you as well to join us at CanAge in advocating for what we consider health equity. So right now, as Heather, if you had that question and you were in the province of Ontario, for instance, you would have a different answer than in the province of British Columbia. Now, what the good news is that the federal government this year kicked in, which is a bit of an unusual circumstance, to cover high dose flu for those who are in long-term care homes is being distributed by the province, but for the first time, the federal government actually helped to support that purchase with federal dollars during the COVID-19. But still, you know, most provinces aren't following the NACI recommendations, and that's one of the reasons why we are advocating at CanAge for a greater coverage, that, you know, NACI recommendations exist for a reason, and that provinces and territories should be emboldened to be able to provide that coverage. To give you a little bit of a sense, just in wrapping up before I head back to John, the problem is that when it's downloaded to the local public health dollars, coverage for a vaccine takes a huge amount of that proportional dollars. If, however, vaccines were covered as part of what we considered sort of drug costs, it would only be about 1.5% of the drug cost covered. So there's a question about where we spend budgets out of. So Heather, that doesn't help you very much because you are in a challenging circumstance, and sometimes you can get a particular exemption or you may need to pay for it privately, and that's the other question. So that is one of the areas that we welcome you to join us in advocating for health equity and positive change to make sure that the NACI recommended guidelines are actually put in practice across this country. That wraps up our session. We have a few more Q&A. What we're going to do is capture those questions, and we're going to make sure that we get you some answers to them and post them up on our social media. Again, this has been recorded, so if you'd like to share this information, do feel free to do so. Again, my name is Laura Tamblyn-Watts, and I'm the CEO of CanAge. We're so pleased and grateful again to our sponsors at Sanofi for helping us to provide with this arm's length educational grant. And at this point, I'm going to turn it back to John Muscedere for the final words from the Canadian Frailty Network, the host of this session today.
So on behalf of the Canadian Frailty Network, just like to also extend our thanks for your attendance at this session today. I'd like to thank Laura and all our speakers for the great conversation and discussion. Please visit the CFN website for further information, specifically on the Avoid Frailty Network, and these presentations are also going to be available on our website. So with that, and one final thanks, we're just going to close it off today, and stay safe. Bye then.
Thanks, everyone.